Okay, moving on to part 3, we're going to do hepatic failure and start out with that, or the liver failure. And I think we may have touched on this in previous modules here and there, but cirrhosis is one of the reasons that the liver will fail, right? That's where you get an inflammation of the liver itself, maybe because of chronic alcoholism or something like that. Hepatitis, certainly. Hepatitis, inflammation of the liver, and cirrhosis is where it gets like all pebbly and destroyed that way from like fibrosis. Okay, hepatitis is the inflammation of the liver. You remember all those A's and E's, the fecal oral ones, and then the B's, C's, and D's with hepatitis, the very dangerous ones. Obviously, that could destroy the liver. Cancer, of course, hepatic cancer. And hemochromatosis. I don't think we've ever really talked about hemochromatosis before. I believe it's actually hemochromatosis, but I'm not sure. Anyway, that's where you get too much iron, and iron builds up everywhere, not just the liver, but the liver is one of those, again, it's a filter, right, for toxins, and it will collect things, so you could certainly destroy the liver with hemochromatosis, where you literally have way too much iron in your body. Okay? Now, signs and symptoms. Okay, again, I'm talking about building up of toxins or ammonia that affect your brain function. This is why this is in this module, right? Because if you get enough of enough toxins in your body, like ammonia, that normally are washed out, they're normally cleared out by the liver, detoxified, that sort of thing. Well, with a failure of the liver and hepatic encephalopathy, then you can actually lead to manifestations at a neural level. Okay, and of course that's what this means, right? Changes in nervous system function. Okay, that means altered level of consciousness. Okay, your reflexes are severely diminished, and the behavior, of course, because basically when you have liver failure, hepatic failure, with that buildup of toxins, you're poisoning yourself. So you get symptoms that would make sense with poisoning, including behavioral changes and your reflexes not working right and your consciousness not working right. So that would kind of all fit in. Poison. Okay. All right. Obviously, if you're checking for your ammonia in your blood, then that would definitely show that you're having liver failure or liver problems, especially. And of course, you could biopsy if you absolutely needed to, although it's not necessarily the best thing to go chopping around until you figure out why. Okay, seizures. One thing I need to make clear is a seizure is simply where the brain's electrical function is just not working correctly. Okay, so some kind of disruption, hopefully brief, otherwise you die. And a seizure is if you have, well, I'll get back to that with the difference between seizures and epilepsy and convulsions. Now, seizures is another word for convulsions. Okay, they are not the same as epilepsy. If you have repeated convulsions, it could lead to epilepsy. Okay, but seizures are the same pretty much as convulsions. I don't know if there's a difference there at all. It's different words. Alrighty, so everybody I think knows what a convulsion is, right? If it's really bad, that is. Okay, jerky, that's that tonic-clonic one. So when you're talking about tonic and clonic, contracting is the tonic part of it, or the tone, increased tone, and the relaxing part is the clonic part of it. Okay? Anyway, that's what we typically think about when we hear seizures. There are certainly other kinds, and we'll look at that. Okay? So again, epilepsy itself is a condition which no underlying correctable cause for the seizure can be found. So you can't say that he has whatever, meningitis or something like that, because you can have seizures with meningitis, but you don't have epilepsy because there's actually a cause to it, and it has to be correctable too. Okay? With epilepsy, all it really means is that seizures keep happening over and over again. Okay? Now, as far as seizures go, a little bit more detail in this is there's a whole lot of there are a whole lot of different aspects to seizures. One thing though is you would have normal nervous function, okay, and your brain tissue is actually intact. So you're not talking about some kind of mechanical damage. There's nobody took a chunk out of your brain or something like that, and your nervous system actually works. Okay. And of course, the right amount of neurotransmitters. So all of these things, what we're talking about when I say normal neural function, okay, to be considered a seizure, you would have to pretty much have these parts of it normal when you're not really having the seizure, okay, if that makes any sense at all. Again, if you have some kind of serious brain malfunction or something like that, then it's not really going to be called a seizure. It's just going to be called whatever that damage was, a severe concussion that caused a seizure, or meningitis that caused a seizure, or whatever, what have you, and a tumor that caused a seizure. Okay, so these seizures, again, they're a huge spectrum, anywhere from a regular daydream, where you're just literally sitting there and kind of dozing off into space, looking out there and just kind of looking out, and nobody's paying attention. You're just kind of out there, kind of like a lot of students are typically during class, right? Daydreaming. All right. Anyway, or forceful contractions and unconsciousness. That's the bigger ones, right? More along the lines of the tonic-clonic seizure. Okay, they can pretty much happen. C-L-O-N-I-C. They can pretty much happen, day or even at night while the patient is sleeping. Although when someone's sleeping and has a seizure, a lot of times people won't notice, of course. But it just depends. Again, I keep saying it over and over. It really depends on the origin or the extent of the dysfunction. Why did it happen in the first place? Okay. Again, you have isolated instances of a seizure. You do not have epilepsy, but an isolated instance of a seizure if you have, like a high fever or even hypoglycemia. Alrighty? Again, it's not epilepsy. You're just having a seizure because of a high fever or a seizure because of hypoglycemia. Okay? An aura. Okay, an aura is when, same thing in migraine headaches pretty much. You kind of know it's coming on. You have like a little warning, and maybe it's some kind of a smell or taste even, or even a sound. Okay, but you have some kind of little aura or visual even. But you kind of know that a seizure is coming on when you have an aura. All right, so let's kind of back up a little bit and look at the neurons themselves. Of course, neurons, nerves, they send signals, to and from the body out back to the brain, right? So, if this is an axon sending something away, and say this is a dendrite sending a signal in to the brain or the central nervous system, that cell body of the nerve, then that's what they're doing, right? They're sending signals away, they're sending signals back in to another one, and they need neurotransmitters to be able to do that. So when the electricity is coming down here, which is kind of what I'm drawing right here, well, I guess I can do it that way and make my little terminal end bulb a little bit bigger right there. And when it's coming down there, then of course it has to stimulate the neurotransmitter to come out of there and go in its little receptor on the end organ, whatever that happens to be. Alrighty, so you need those neurotransmitters. Epinephrine, of course, are stimulating, so we could say that these little neurotransmitters are epis. And GABA is inhibiting. I think I already talked about this. So GABA would go ahead and, well, actually probably down here, would kind of chop it off so you can't get the signal through, and therefore you can't stimulate anything. Alrighty. Again, the same kind of idea here. Afferent are sensory. Afferent are sensory, same thing. And they're carried from the back or the dorsal horn or the spinal nerves into the central nervous system. Somewhere along the line they have to encounter a relay station like the thalamus, which is in the midbrain, and that has to kind of make a decision. Okay, once a particular action is determined or a decision is made on what to do with that impulse that came from the sensory nerves, then motor or efferent nerve impulses, they travel to the ventral or front horn of the spinal nerves, and they cause that motor reaction. Okay, this is normal nerve transmission. Okay, so if you have massive overstimulation, as in that synaptic neuron is getting way overly stimulated, now you got just tons of, for example, epinephrine trying to get in there into that, into the receptors and everything. Well, that's basically a forceful muscle contraction, right? So now we're talking about just overstimulating that muscle over and over and over and over again, and the next thing you know, you're kind of spazzing up, right? That's what a convulsion really is, isn't it? It's just a kind of a tetanus, really. Okay? So seizure classification. There are different ways that they are classified. And what was traditional is basically you had the grand mal seizure, that jerking and spazzing kind of thing, and then you had the little petite mal that didn't really seem like you're doing much, just kind of daydreaming. Well, now they have a new nomenclature out that is supposed to be taking the place of the traditional, and you have your seizures overall, and then it breaks it up into only two categories, right? So you got partial and generalized, right? Partial is local and kind of one spot. Generalized is all over. So this, in the generalized part, the entire brain is being affected, not infected. And the partial seizures is just in a local spot. Okay, as far as that goes, they can either be simple or complex. Okay, everything else is the other one. Everything else is considered under general, so that makes it a little bit easier, I think, to kind of classify them. As all you do is remember one, and I would suggest the small one, and the other is the other. Okay, let's go back to these tonic-clonic seizures. A little more detail. Again, they used to be called grand mal seizures. In fact, they still are called grand mal seizures in most cases, but it involves, like I said, both brain hemispheres. Okay, so it is generalized. Okay, this is the one that you see all the time. That one you don't see it all the time, I hope, but this one you hear about all the time. The big stiffening part of it, the person spazzing out, and then all of a sudden they start jerking, or the clonic phase of it. Okay, they lose their consciousness. They really can't breathe very well when they're in a seizure. They might bite their tongue and lose their bodily functions, wet themselves or something like that. Okay, those episodes, anywhere from seconds to several minutes. Obviously, it's more severe the further along you go with low oxygen in a seizure. And then there's usually a post-ictal period where that person, it may only last, a few minutes, it could be hours, but their post-ictal period is where that person is not really with it. Okay, they have an altered level of consciousness during that time, and they're just kind of dazed, I guess is the way I would put it. Okay, they're not really quite back with you yet. Dazed, that's a D, believe it or not. Okay, so contrary to what's shown in the movies, nothing should be put into the person's mouth. Okay, any objects around the patient should be moved to avoid injury, like jerking motions. And they don't want to hit something within a patient. Don't put them under a glass table, right? And the patient should be rolled to one side to prevent choking. Okay, now if for some reason they lose their airway or vomit in themselves, then you have to deal with that, right? But whatever you do, do not stick your fingers in their mouth and try to keep them from swallowing their tongue. Honestly, it's not going to happen. I'm not even sure if that's physically possible. But either way, the odds of that happening are much, much, much less than them biting your finger off if you try to stick it in there. Okay. Absent seizures, again, person seems like they're daydreaming, so they're just little Billy's just sitting in this class minding his own business, and all of a sudden he's just kind of just kind of out of it, just staring off in the middle of nowhere, and you're like, hey Billy, what is the answer to this? And he's just kind of staring there. He doesn't even know you're there. Okay, doesn't know what's coming on. There's no prodromal period. It doesn't look like he even loses consciousness, and when he wakes back up, he's just back there. Okay, he probably has no idea he even had a seizure. It's just kind of like, what are you looking at me like that for, right? Pretty short, 10 to 20 seconds. Don't know, again, what has happened during the seizure, but you're awake after the seizure, okay? This is kind of, if you attempt to speak to this person during the seizure, you will not get a response as compared to daydreaming. Okay, again, this is what we see in pathophysiology all the time, right? You will not get a response if you try to speak to that student during his absent seizure, which apparently is rampant in this class. Okay, just kidding. This is often seen in children and can occur several hundred times per day. If severe, that would be very severe. But again, you see that a lot more in children. They tend to outgrow those, actually. A lot of times, by the way, you'll just have a seizure for no apparent reason as a child and you never see one again. That is not that uncommon. Okay, again, simple, as in it's an isolated impulse in the brain and not generalized, okay? This is simple partial. So it really depends on where the overstimulation, and that's what these are, is overstimulation, right, of that nerve, where it is in the brain, depending on what's going to happen. So you see a few different things. You'll see a motor aspect of a simple partial. You'll see a sensory aspect. You'll see a autonomic aspect, and you'll see a psychological aspect. So you got these four different parts to a simple partial seizure. Again, maybe that motor part, is kind of jerking around a little bit. Again, you're not talking about a grand mal here. You're just talking a little bit. Maybe the head is turning back and forth, back and forth, back and forth. Or maybe the speech, vision, hearing impairment happens. Okay, so again, it's not nearly as bad as a grand mal. That jerking, the head turning is more mechanical. Boom, 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 kind of back and forth a little bit. Okay, the sensory manifestations of a simple partial seizure usually are explained like more of an unusual sensation. So you're sitting at your desk and all of a sudden you smell burning toast, right? Assuming that there's no toast burning everywhere around you, then you maybe get this little unusual sensation, or maybe even call it an aura, right? So autonomic, that means that your vital signs or your body temperature or something, I guess that is what are your vital signs, is changing. Okay, so your autonomic system, your automatic system is sensing that you're having a seizure, and you'll change some of those factors while you're actually having it. Okay, psychological, sudden change of emotions. Okay, so yeah, you would see that in a simple partial seizure where somebody is just again, they're overstimulated in the brain, so it's going to definitely affect their psychological function. Okay. Some of these patients, again, simple partial. You're not talking about a huge grand mal seizure. Some of these patients are just saying, "Oh wow, deja vu," and hey, has this happened before, kind of thing. And again, might last several minutes. Consciousness is maintained, so it's not like this person's falling down and gagging on his saliva and biting his tongue off or anything like that. He's still there, just kind of sitting there, just out, even though he's kind of looking at you. Okay, it can progress, certainly. Okay, so they can get into a complex partial, even a generalized seizure, if it spreads to the other parts of the brain, and then of course you may lose consciousness. Okay, now that was the simple partial. Now we're talking about the complex partial. Again, these are your two partial seizures that are the localized one, right? So we're still at one area of the brain, and this you may have a prodromal warning. Okay, what did we say about the simple one? No, that wasn't what we were talking about, was it? Yeah, we were talking about absent seizures, the petit mal one where you have no prodromal warning. Well, in the complex partial seizure, you may have one. Okay, I think that's supposed to be lose awareness. Okay, may have a prodromal warning and then lose awareness and appear to be staring into space. Okay, sounds very familiar, doesn't it? If you address the person, you will not get a response. Okay, same as that simple partial seizure, right? Everything actually pretty much is the same so far. Often accompanied by automatism, which is person may make chewing, picking, or other non-purposeful involuntary motions. Again, remember the last one, the simple partial seizure, where they turn their head back and forth, back and forth, back and forth. Well, this one might be doing the same kind of thing. Maybe it's chewing or picking or something else. It's just kind of going back and forth, back and forth, back and forth. Okay, chew, 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 chew. Okay. This one can last up to several minutes, so they tend to be a lot longer, where the simple partial seizure, if you look back, was a lot shorter. It can last several minutes, but they tend to be a lot shorter. Okay. May have a post-ictal period from minutes to hours. That sounds exactly the same, doesn't it? And can affect anyone, but is often seen with some type of brain injury, such as trauma or infection. Okay, if you want to see the differences between the simple and complex seizures, then go and click on that video and you can watch that. Again, you can't click on it in this video, but you can click on it on the other PowerPoints. All right, does this depress you yet? Okay, because we're talking about depression, going into a depression kind of slide. Oh, he looks very sad. Okay, what are signs and symptoms of depression? Well, you're sad, apathy, you don't really care, whatever. Weight, appetite changes. Sometimes that's gaining, sometimes that's losing. Decreased energy. Oh dear, we're just out of energy. Suicidal thoughts, if you had enough energy to do it, that is, but you may not. Okay. Mood swings, insomnia, crying. This is all typical depression signs and symptoms that I think everybody's probably more or less familiar with either way. All right. Anybody can get depression, right? Children, adults, elderly. Of course, anybody can get depressed. If it's major depression, then that has to interfere with your life, your job, your family, your sleep, eating, studying, whatever. But major depression has to interfere in some way. If you're just feeling all of these symptoms and you're still functional and you're still going to school, going to work, doing what you need to do, you're just bummed, then it's not major depression. Okay? Having said that, with adolescents or teenagers, it's very, very hard to diagnose what is normal or what's changed from normal, because, let's be honest, you get a lot of this in teenagers, whether they're depressed or not. Okay? So, anxiety, anger, avoidance of social interaction, some big red flags even for teenagers. Okay? Postpartum depression, or sometimes referred to as baby blues. All right, signs and symptoms of intense anger, severe mood swings, thoughts of harming self or baby. Okay, again, postpartum depression. Postpartum psychosis is the part that kind of goes with the signs and symptoms of the mood that you see here. So the psychosis part of it, now you're confused, hallucinating, paranoid, attempting to harm self or baby. Again, the same thing. But this is real. Postpartum depression is actually very, very real, and it's easy to say, to say, well, what kind of mother would think about harming yourself or your baby, but you see it in quite often, and it's literally a hormonal thing, because the hormones are just through the roof at that point, and they're taking such massive changes that it is a very real situation. Okay, seasonal affective disorder is different, of course. That onset in fall or winter, you really don't see that in Arizona, I don't think, very often. But you catch the Midwest states, like the Illinois, the Indiana, the Idaho. That's Idaho, Indiana. You catch those Midwest states, Michigan, that sort of thing, where it snows and then it gets pushed off by the plows on the side of the road, and it's gray, and the entire winter is gray, and now the snow is dirty and mucky, and everything you're seeing is gray for the entire time, and it's cold, and people just get really depressed is really what it is. It's depression based on the seasons, okay? And you see that actually fairly often in the Midwest, northern Midwest states, okay? Dysthymia is less severe than major depression, okay? It can last for a long time too. Why do you have, I don't know, you have depression for all sorts of reasons. It just really depends. Sometimes they're, again, severe, and sometimes they are not so severe as far as physical or psychological goes. But either way, you have to deal with it with psychological testing to find out what the problem is, and then take it from there. The DSM, the Diagnostic and Statistical Manual of Mental Disorders, they just call it the DSM. DSM. Now I think they're still on 4. They may be on 5 or 6 for that matter. I don't actually know. But the DSM, Diagnostic and Statistical Manual of Mental Disorders, is where you would actually find all of these mental disorders, in fact, and the complete definitions of them. Okay? Again, we have therapy, behavioral therapy, we have medicines, depending on what the cause is of that depression. I need to break this one off again for time. We'll pick up schizophrenia next time.